Medical Center. Before we move on to the case, doctor, is there anything that you want to tell the audience?
Nothing, but yeah, this is quite a common case lah. For medical students, I guess, in the exams, it's one of the cases which I think Prof Kwan will call it a type A case lah. Everyone is expected to do well. So yeah, that's it lah.
Okay, yeah. Now we shall move on to the case. So it's a case regarding knee pain. And moving on to our patient here. So our patient here is Mr. L. YW, a 75-year-old Chinese gentleman. So he first presented with bilateral knee pain for the past 1 year. And regarding the history of presenting illness, the pain was on bilateral knee and localized towards the medial aspect of the knees. And the onset of the pain is gradual and it's progressively been worsening over the past 1 year. So regarding the character, it is sharp in nature and usually worse after movement. And also, it is also worse on the right side as compared to the left side worse on the right knee as compared to the left knee. There's a typo there. And the pain is usually relieved by rest along with some painkillers, which he ingests oral Celebrex when required. So the PAN score out of 10 is 6 to 7 while walking for long distance and 3 to 4 while resting. Moving on, it is also associated with stiffness during the morning, which is relieved within 30 minutes of walking. There is also night pain, of which he wakes up due to the pain. However, there is no associated numbness around the lower limb, and there's no back pain associated with the knee pain. There's no preceded trauma on both knees prior to the onset of the knee pain. And also, there's no swelling or any skin changes around the knee. For the constitutional symptoms, there's no fever, no loss of weight, no loss of appetite, and no night sweats. Upon further history, the knee pain actually started 10 years ago. He then sought treatment in PPUM or Pusat Perubatan UM, of which he was diagnosed with osteoarthritis for both knees. He was initially referred for physiotherapy, but it did not work for him. And he eventually opted for intra-articular hyaluronic acid injection. And he's still refractory to the treatment, and the pain progressively worsened over the years. He was then scheduled for bilateral knee replacement during this admission. Since the onset of knee pain, for his functional status, he was originally able to walk up to 1 hour, but recently, over the 1 year, has only reduced to approximately 3 minutes before he had to rest because of the pain. He's also unable to jog or run due to the pain. And however, he does not need any walking aids and is still able to climb stairs, but has to take 1 step at a time. So regarding his past medical history, he has underlying hypertension, of which he was diagnosed 30 years ago, and currently is on 2 tablets of losartan once daily and nifedipine twice daily. And he's compliant to both medication. His systolic blood pressure is usually around 120 millimeters of mercury during self-monitoring, and is on follow-up at RUCA for every 6 months. He also has underlying dyslipidemia, which was diagnosed also approximately 30 years ago, and currently on oral simvastatin, and is compliant to the medication. There's no non-food or medication allergy. There's no history of traditional medicine use and no steroid use as well. There's no other sites of joint pain prior to this episode. It's bilateral cataracts as well, diagnosed in 2018 and underwent operation, later we will mention. And also there is obstructive sleep apnea. He was just diagnosed a few months ago, which he requires CPAP during sleep. With his past surgical history, he underwent hemorrhoidectomy around 20 years ago and recovered uneventfully. So also underwent fecal emulsification for his bilateral cataracts and intraocular lens implant on both eyes, which was done in 2018 and 2019, which was 4 years and 3 years ago, and recovered uneventfully. So for his family history, it is quite significant, as there's 4 other siblings also suffering from knee pain. 2 of them, which are diagnosed with osteoarthritis and underwent total knee replacement. 1 older sister has breast cancer. Aside from that, there's no other malignancy or any orthopedics related issue in the family. for his social history, he's a non-smoker and a social alcohol drinker. He was a retired architect, which he retired 10 years ago, and is married with 3 children, currently staying with his wife and son in a double-story terrace in Damansara. His fees are currently covered by guaranteed letter, as his wife is a government servant. So yeah, at this point, Dr. Khairul, is there anything to add on or to emphasize on during history taking?
Sorry. Yeah. That was okay. The history was quite complete lah. You focus quite well on the past, on the history of presenting illness. The main complaint, which is knee pain, and you specifically ask for a specific site. And then the good thing is that you described it quite typically of how osteoarthritis will present lah. Mechanical pain, progressively worsening over months to years. The nature of the pain. The associated symptoms, I guess, can be a bit more detailed lah. What I notice is you guys confuse morning stiffness and reduced range of motion, which for me reduced range of motion is stiffness. Morning stiffness is a bit more subjective to the patient lah. But yeah, it is important to ask about morning stiffness. But more importantly, especially in osteoarthritis, you should ask about the reduced range of motion lah, which is the actual stiffness. So for the hip, they have a bit more complaints in terms of stiffness. But for the knee, I think it's quite common that patients say they cannot fully flex, and that one functionally is it's squatting lah. So earlier on, patient will lose the ability to squat. And in Malay patients, Muslim patients, they will lose the ability to pray normally, and that's quite important. Not important, like something which gives you a clue towards a diagnosis. I know this patient is Chinese, but yeah, sometimes you can just add on about the reduced range of motion. You did mention about numbness and weakness, which I think is fine. And then next you went to the event history lah. So I think if you guys have classes with Prof. Chris, I think he did emphasize on you shouldn't emphasize so much on the events. You should emphasize a bit more on the symptoms lah. So but yeah, you did say that patient went through physio and injections, and that indicates that the patient has failed conservative lah. Next, you ask about the function, the walking distance, the ability to jog and all that. I guess for the more elderly patients, jogging or sports lah is not so important lah. That one more for younger patients. For the more elderly patients, they just want to go shopping lah. I guess that's quite important. Go shopping, even go to the market, and sometimes the pain stops them from doing it. So you should focus. You should ask a bit more around that lah. Because yeah, elderly patients, they retired, like, so don't do so much. Sometimes they just want to spend their time, walking around shopping malls, go to markets and all that. Sometimes the pain hinders them to do it. Okay, and then yeah, past medical history is fine. Past surgical history, it's also. Oh yeah, past medical history. I like that you asked specifically about joint pains elsewhere lah. But I guess that can come under associated symptoms as well. Past surgical history is okay. Family history for osteoarthritis, it's not so important lah, family history. But yeah, I guess you want to make that a habit, so that's fine. Yeah, social history, the most important is the occupation lah. Especially if patient is retired, you should ask them what they normally do lah in a day. So I know some elderly patients in the morning, they like to go to the park and do the exercises and all that. Sometimes because of the pain, they're not able to do that. So yeah, in terms of social history, you should ask the patient what they can or cannot do. And then you asked about the double-story terrace house. You should specifically ask where the patient's room is lah, and if they have any problems, because sometimes when the room is upstairs, they tend to stay more inside the room. They don't want to even go downstairs because of the pain lah. Yeah, but that is a very fine details lah. Okay, any questions?
No, that is quite comprehensive.
Yeah, from your friends.
We will later open up the chat box during the Q&A session now.
All right, fine. Okay.
Moving on to the physical examination. So he's alert and conscious and breathing comfortably under room air when we examine him. He's pink and there's no walking aids around him. There's a 20 gauge cannula on the right antecubital fossa and a CPAP machine over the bedside. Upon inspection of the knee, anteriorly, there's no shoulder or any pelvic tip where it's standing up. And there's a visible genovarum deformity, which is worse on the right knee. Later we'll show the picture. There's no scars or skin changes over the anterior aspect of the knee. However, there's swelling over the bilateral knee, which is worse on the medial aspect. There is also quadriceps muscle wasting that is more apparent on the right side. So from the side, there is no hyperextension of the knee joints, and posteriorly, there's no swelling or any scars. When we ask him to walk, the gait is antalgic with shortened stance face on the right side. This is the picture. Can mention, see, especially the most striking one is a genovarum deformity, along with the swelling on the medial aspect. Yep. This is from the side, there's no hyperextension. At the back, there's no swelling, no scars. Ideally, of course, we would like to ask the patient to take off their slippers. Okay, so while seated, their crepitus felt bilaterally and bilaterally over the knees upon passive extension and flexion, and patella tracking is normal. There's no increase in warmth over the knees, and knee passive flexion is reduced bilaterally, which is up to 120 to 130 degrees, while knees active flexion is also up to 120 to 130 degrees. However, the knee's passive and active extension is in full range of motion. There's no posterior, when we ask the patient to lie down, so there's no posterior sag or and the tibial step off is felt. And upon palpation, there's no medial joint line tenderness, and all the bony landmarks are present, there's a typo there, and non-tender. There's reduced joint space, which is more apparent over the medial joint line bilaterally. Patella tap and bulge test is negative, and anterior and posterior drawer tests are negative as well. Lackerman test is negative as well, and the varus and valgus stress test is negative. McMurray's is negative as well. Moving on, for the distal dorsalis pedis artery and the posterior tibialis artery, they are both palpable, and pinprick sensation according to peripheral nerve distribution is preserved. Yeah, so that is it for the physical examination. Is there anything to add on, Doctor, for the PE?
Okay. Yeah, everything is complete lah, but I guess you did not really follow the what's the word for it? The flow. Go back one slide. So yeah, this it's look, feel, move. So you look first, which is good. But look at patient standing, and then you sit up the patient. And then you look at the patellar tracking, which is fine. And then patient lie down. You palpate. You inspect another time. Which I guess you did put the two pictures together lah, when patient standing and patient lying down. And then you feel. So feeling is initially you feel in extension. And then you check for presence of effusion. And last is only you check the range of motion lah. So the flow is a bit wrong lah. For medical students, it's important lah. For masters, I guess we don't really put too much fuss. But yeah, for medical students, sometimes you want to see that flow lah. Look, feel, and then move. So the effusion should be before the range of motion. Okay. okay, this patient probably does not have lah, but in patients who have very bad varus, go back to the picture again. The pictures, yeah. Okay, so this one, I guess my comment is when patient is lying down, you did put the ankle together. When standing up, you didn't. So if you say the patient has a genial varus, you should actually put the ankles together lah. If they cannot put the ankle together, then and the knees are together, then you can say patient got valgus. But if patient standing together, standing, and the ankles can come together, and the knees are far apart, then you can confirm say that the patient has virus. So that's a trick that you can do lah. And then you should actually face the patella forwards lah. So this one you can see that the right side, the patella is actually not facing you. The left side is better, but still it's a bit external rotated lah. So sometimes you can because you're looking from the side, right? So sometimes you won't you'll miss that varus lah because the patient is externally rotated. Yeah, that one master student also do quite a lot of mistakes. So you need to show the examiner that you've done this many times, and you need to show what position you want the leg in to demonstrate the varus. And then for this patient, yeah, probably doesn't have lah, but patients very bad varus, you can see a varus thrust lah. And then during general inspection, you should also look for signs or stigmata that the patient has a non-primary osteoarthritis lah. Should look at the toes, whether there's any obvious deformities. Look at the hands, look at the elbows. Sometimes they have these rheumatoid nodules, which you can comment on and will give you a lot of marks lah. Okay. Yeah.
Doctor, actually I have a question. If during PE, theoretically they usually say put the ankle together and measure the distance. In terms of practical wise, is it really practical to do so to establish how many cm it's varus deformity?
If you're very confident with your examination, you feel like you have a lot of time, then yeah, you can measure lah. Because when patient stands up, the varus is actually a bit more, and when they lie down, it's less because they're not weight bearing. So you measure when they're standing, then when they lie down, you can say, oh, the varus basically disappears. So most likely the deformity is correctable, but it's not a must lah. I mean that's just for extra marks lah. But yeah, to demonstrate varus, I think it's good that you put the ankles together and just say, okay, the knees are further apart. You don't really need to measure lah. That's optional. But if you do measure, then you can explain more lah.
Thank you, Doctor. Now, after we have the history and PE, moving on to the provisional diagnosis. So it is quite obvious that this is a bilateral primary osteoarthritis of the knee because of the points that point towards the OA of the knee. It's the progressively worsening mechanical pain that has been lasting for years, and his age and his response to anti-inflammatories in terms of his pain as well, and also with his with his stiffness. And during our physical examination, there's also varus deformity, reduced range of motion, there's crepitus present upon palpation, and also tenderness over the medial joint line. Moving on, for the differential diagnosis, we actually need to rule out whether there's any secondary osteoarthritis in the history. In the history, there's no any trauma, no rheumatoid arthritis. However, I'd like to, moving on to the other differential diagnosis, that will be rheumatoid arthritis. However, the history does not really suggest any inflammatory pain. And RA, from what I understand, rarely present on large joints without any small joints involvement. And there's no localized increase in wound bilaterally and no rheumatoid nodules present in any parts of the body during our examination as well. Over another differential diagnosis is a small typo there. medial meniscal injury due to localized pain on the medial aspect of the knee. However, there's no previous history of trauma. And upon physical examination, McMurray's test is negative. Going on to other differential diagnoses such as gouty arthritis, it is also less likely because it's quite rare over the large joints, and history is not suggestive of any inflammatory pain or any previously diagnosed gout. And physical examination does not reveal any localized increase in warmth, and there's no gouty tophi that we can visualize anywhere in the body. So moving on, lower down to the list is septic arthritis. So something to be ruled out, but unlikely because there's no fever or any constitutional symptoms, and the chronic presentation doesn't really point towards infection as well. There's no overlying skin changes over observation and examination, and no localized increase in warmth or effusion during the physical examination as well. So yeah, Dr. Khairul, any other things that we need to take note of when we are considering provisional or differential diagnosis?
Okay, so if you look at the point towards lah, so age, ethnicity lah, Chinese do get more OA than Malay or Indians, and then the duration of symptoms is years, right? So patients who come like this, 95% of them will be primary osteoarthritis lah. But the onus is on you to exclude the other 5% because it has been missed before. And if it say it's RA, then you diagnose OA, then the management won't be optimal lah. Like I said, it has been missed before when patients have been going through treatments for very long and then they realize it's rheumatoid arthritis. It doesn't look good lah. Yeah, so the point towards most of the time patients will have a progressively worsening pain and they will have a deformity. Most patients know they are bow-legged or knock-leg. They are a bit more elderly and the response to the medications is quite good lah. But patients, yeah, they do have a bit of variability in the stiffness, in the symptoms. Sometimes the morning stiffness stays a bit longer. Sometimes they do have the night pain, but the night pain, if it's every night, then you have to look harder for other causes lah. But it's certain nights, especially after they do a lot of exercise, then I guess it's fine. Then yeah, patients who have OA, usually after intra-articular injection, they will have a response lah. And if it's very short, so it's never mind. But if we injected the knee and there is a reduction in pain, then we're quite sure that the pain is not the pain is actually coming from the knee lah. Because some things which you have to consider is also patients who have knee pain but the hip pathology is in the hip or the spine. But yeah, I guess that one is a bit more master's level lah. And then yeah, you really have to exclude the other 5% lah, which is the next slides, which is rheumatoid arthritis, secondary OA. Yeah, meniscal injury is, I guess, more sports lah. But yeah, for patients with secondary OA, sometimes in the knee also there is AVM lah, even though it's more common in the hip. But you need to think about it, especially in patients who are a bit younger lah. And you find out that they drink quite a bit, or they take quite a bit of steroids, or they smoke. Patients who also had a recent arthroscopy knee surgery with some knee pain also, they are at risk of having avascular necrosis lah. But that one is fine points lah. I guess you guys no need to focus so much. You guys need to make sure it's not inflammatory arthritis lah. That's the most important. Rheumatoid, gout, or septic arthritis. Okay.
Thank you, Doctor. So moving on in the investigations, so did a few blood parameters such as full blood count, but it's not significant no raised values or decreased values. Differential count is quite normal as well. Renal function test, his EGFR is lower, but 70 not too bad because he's might be due to his old age as well. And his liver function test is normal as well. Moving on to the coagulation profile, no coagulopathy seen. Yeah, that's all for the blood parameters, which is quite insignificant in this case. However, moving on to the radiology. So we took a lower limb full length view on 7th of April 2022. And from what you can see, so interpretation of the X-ray, there's reduction of knee joint space bilaterally and also predominantly on the medial aspect, giving rise to genial varum. Later, we will see a closer picture of that. And also there's mild reduction of joint space over the hip joints. However, there's no cortical break or lucency to suggest any fractures, and there's no suspicious bone lesion since. So this is the mechanical axis to demonstrate that it is a genial varum. Okay. So yeah, also bilateral knee skyline view was being done. However, there's no reduction in patellofemoral joint space. However, there's some marginal osteophytes that can be seen over the patella. And this is a right lateral weight-bearing view of the knee. So you can see that there's marked reduction in joint space and also multiple marginal osteophytes that can be seen all over the knee. And this is the right epi view of stress radiography of the knee. So it can be seen that there is reduction of joint space with subchondral sclerosis when varus force is being applied over the right knee. Also, this is for the left knee, left lateral weight-bearing view. There's again reduction of joint space with multiple marginal osteophytes. And now another stress radiography of the left knee epi view. And so we can again see the reduction in joint space with subchondral sclerosis and also some marginal osteophytes that can be seen. The reduction in joint space is very apparent during a varus stress, when varus stress is applied. Yeah, it's mostly from the investigation itself. Doctor, is there anything to add on regarding the investigation itself, especially the radiograph?
Go back to the long limb. Yeah, so this is the I guess this is the most important X-ray you should this one lah. The bloods, I guess, not so important, but if you do suspect that the patient has autoimmune or inflammatory, then you should actually ask for rheumatoid factor, anti-CCP and all that lah. So for the X-rays, yes, it's quite good. So the reduction of both joint lines, especially at the middle aspect lah, you can pretty much say that the lateral compartment is quite normal, and that's also prevalent. It also shows on the stress views lah. Subchondral sclerosis, osteophyte, subchondral cyst, I guess that's a bit more secondary lah for the diagnosis. So you go to the anterior, the stress views. So this one, I draw the line. I guess if you want a bit more extra marks, you can just say that the X-ray also correlates with the various deformity lah. So you can see if I draw a line from the hip to the ankle, in a normal knee, it should go through the center of the knee lah. But for this one, you can see that it's actually going through the medial side, which means that it's varus. Okay. Yeah, this one. Okay. Patellofemoral, for me, this is okay lah. Don't read too much into it. Okay, next. Marginal fat. You can say there's probably some osteophytes around the trochlea at the femur there. But otherwise it looks quite okay lah. Okay. Yeah. So this one is the. Well, this one is actually more for our pre-op planning lah. But you can see in the various stress switch, basically it's you put load on the medial side. You can see that's clearly there is a loss of joint space over the medial side. Whereas in the valgus stress, you can see that the medial side opens up, whereas the lateral side it doesn't close down. So we're quite sure that the lateral compartment cartilage is normal. But yeah, this is more for pre-op. It doesn't really help in the diagnosis, I guess. But you can see that it's clearly loss of joint space. And the subchondral bone, especially around the tibia, is quite sclerosed. Okay. Yeah, then the left side is basically the same lah. Okay.
Yep. Moving on. Sorry, short question, doctor. So regarding for our level, if we were to mention, I want to see whether there's any reduction of joint space, we can just mention that weight-bearing view, right, instead of stress radiography.
Yes.
Okay.
But when you, I say, they probably might ask you like how you know the X-ray is actually adequate, or how you look at the X-ray and decide whether it's good enough for diagnosis. So obviously first you need to determine whether that's the correct patient, and then the correct joint, I guess, and then the good penetration. So for this one you can see lah that the bone is quite wide, so that's quite okay. And then the rotation is also important lah. You same like your physical examination, you need to make sure that the patella is actually facing forwards. So for this one, yeah, the patella is it's quite at the front lah. There are some X-rays which for me doesn't look so nice because the patella is more over the lateral side. Sometimes it might show, it might not give you quite a good view lah of the wear. So yeah, but yeah, they might ask you that lah. They might not, but yeah, sometimes they just might ask you that.
Okay, moving on. Yeah. So for his management, you can divide into non-operative and operative as well, of course. So for his non-operative, celecoxib 200 milligram taken when required for analgesia is being prescribed, and also we referred him to physiotherapy. Well, which in the history we do notice that even with intra-articular injection doesn't work. So that's why we move on to operative, which was total knee replacement, and pre-op we did prescribe IV cefazolin 2 gram and also Surgibath. Okay, so operation was total knee replacement, and then this was being done, which is
it's not totally lah.
Oh yeah, it's bilateral unicompartmental knee replacement done. And this is the radiograph post-op. So yeah, can see that there's no peri-implant lucencies around the implant, and then multiple surgical clips can be seen over bilateral knee region. And yep, moving on to the right knee weight-bearing view, right knee weight-bearing lateral view, and also the left knee weight-bearing lateral view. You can see that again, the same thing, no peri-implant lucencies. And yeah, skyline view, like prior, there's no reduction in patellofemoral joint space. Yep. And for the post-op plan, he was allowed orally once fully conscious, and cryocuff will be put on bilateral knee, and cuff pump for bilateral lower limb as well. And to reduce the swelling, to elevate with pillow at heel, and cefazolin 2 gram IV 3 times daily was prescribed, and celecoxib and tramadol and paracetamol was given for analgesia. And wound inspection on post-op day 3, and removal of suture on day 14 post-op. Of course, last but not least, need to refer this patient for physiotherapy to regain his normal function. So yeah, it's mostly for the management. Yeah, doctor, anything to add on regarding the management for OA, particularly in this patient?
Yeah, I guess you shouldn't use this patient so much to determine the management lah. because I guess what is expected for you guys is you should know how to treat OA lah. And a large part of it, or 90% of patients lah, will undergo conservative first. So conservative, you should, when you describe the management, like you should divide into, okay, I want to treat the patient conservatively. My management can be divided into pharmacological and non-pharmacological lah. So pharmacological, we know that the evidence is quite good in terms of the anti-inflammatories. So you can say I will prescribe anti-inflammatory to the patient lah, NSAIDs, and this is Celebrex. There's also supplements, pharmacological supplements, which can help reduce the rate or reduce the progression lah. So previously people used to talk about glucosamine a lot, but now it's been, I guess there's no good evidence for glucosamine lah. And then there's the newer things which we do try, probably not so important to know, but if you are interested, you can read lah. There's the interleukin-1 inhibitor, which is the Atroda. And then there's also the saponified soy, which is piasclidine. So those two things are quite new, and it's part of the pharmacological lah. Okay, and then the non-pharmacological, I guess, is the most important, and there's a lot of evidence for that already. So for the non-pharmacological, the first and most important, which we tell every single patient, this patient needs to reduce the load on the joint. So how to reduce the load on the joint? The number one is you should lose weight lah, because actually we know that your body weight, the weight that goes through your joint is actually 4 times your body weight. So if you lose 2 kilos, actually you reduce the load on your joint by about 8 kilos. So that's the first non-pharmacological, which is first method lah. Basically reduction in body weight, and then you can try using walking aids. So there's specific, if you read the osteoarthritis guidelines, they can tell you the mechanism by how using walking aids reduce the load on the joint lah. So for the hip, you use the walking stick on the opposite side. For the knee, it doesn't matter which side lah, but as long as you use it, there'll be a reduction on the load of the joint. So one is lose weight, second is walking aid, and third one is you can do bracing for the joint lah. So the specific braces we actually can offload the affected compartment lah, especially if patient is very bad varus or valgus. So that's the conservative, pharmacological and non-pharmacological. And then before surgery, there's something which is a bit more invasive, which is intra-articular injections. That one is also evidence not that strong lah, but it's done a lot in Malaysia, so you should know at least something about it lah. So you can either inject hyaluronic acid, or you can inject steroids. And then last resort is surgery lah. So surgery is either it's a joint replacement. I guess more commonly in Malaysia, people do the total knee replacement lah. So, but you have to always keep in mind that surgical treatment of osteoarthritis is the last resort lah. Because once you do a knee replacement, then the patients will have the prosthesis there in for life. So we have to exhaust the conservative management before we proceed with knee replacement lah. The specifics of knee replacements, I guess that's not important for you guys to know lah. Just know that the patient undergoes replacement. So for this patient in particular, he did not need a total knee replacement. That's why we did a uni compartment, and the recovery is a bit faster. The peri-operative management, when to keep NBM, what antibiotics to give, inspection and all that is not so important lah. I don't think so. They'll ask you about it for exam. So yeah, can forget about that.
And also, doctor, when we were shown a post-op radiograph, let's say in this case, aside from any peri-implant lucencies, any other things that we need to describe or look for?
Yeah, you just need to know that this is a partial knee replacement lah. So the medial side have been replaced. and you know that this patient is fairly recent post-op because there is still staplers there, you can say that the alignment or the you can say like the alignment has changed from pre-op, because you know pre-op patient is in varus, now post-op it's pretty much normal. Lucencies and all that in the acute setting, especially if there's staplers, we don't really look. You can just say there's no complication, you don't see any fractures. That's it lah.
Okay, so yeah, it's the case for now.
Okay.
For the case, anything to add on before we move on to the Q&A session?
Yeah. Okay. There's a history. For your examination, go back to your slide on the examination. I guess I did write something there, but I didn't comment on it. Go down one slide. Okay, so this one, okay, there is reduced joint space more apparent on the medial joint line. Not sure how you examine for that lah. Well, we certainly don't lah. But we can say patient is varus. And then that's it lah. Joint space reduction, joint space more you see during X-rays lah.
Okay.
So yeah, if you want to say there's tenderness more apparent over the middle joint line, okay, that's fine. But you did say there's no middle joint tenderness lah. Yeah, and then that's the flow. Yeah, that's mainly it lah. Read that, which I didn't comment. Anything else lah. Yeah, that's it.
Okay. So moving on to the Q&A, let me just stop sharing my screen for a bit. Moving on to the Q&A. Oh, yeah. So any of you, if there's any burning questions, just feel free to drop it in the chat box, and yeah, and we shall just read it out. So currently, so far, there's no questions from the floor.
Everyone understand everything very well.
Yeah. Then yeah. Oh, there is one actually. So from Chan Chi Ken, he was asking, Doctor, in this patient, full lower limb X-ray was done. So must we do that, or just a knee X-ray will be enough?
I guess for your level, just for diagnosis, you just say it's you need a weight bearing AP knee X-rays. Lower limb X-rays, I guess, not mandatory, because not all hospitals have the lower limb X-rays. Just because you come from UM, that's a luxury which we do have. But for diagnosis, a lower limb X-rays, I guess, is not so important lah. But you need a weight bearing X-ray lah. So weight bearing AP and lateral views of the knees.
Doctor, personally, I'm quite curious because during clinic we saw quite a bit of patients saying that acupuncture actually help a lot, and for example, those urut actually help a lot. In terms of that, during the counseling of the patient, not so much for exam wise, during the counseling of the patient, should we just say, okay, go ahead and do that, or should we just say refer to physio better?
Okay. So yeah, that one okay. So what my advice is to the patient is that I'm not familiar with this Momo, or I'm not familiar with this acupuncture. I tell them they should try, and if they feel a difference, then by all means proceed. But if they feel like it doesn't help, then they should rethink the use of those things lah. I also tell them that the practice of this acupuncture and the practice of this rope is not standardized. So they might find that their friends say it helps for them significantly, but for themselves, they might go to someone else, and if their problem is different, then they might not feel much difference lah after the treatment. Yeah, but now this traditional Chinese medicine TCM, it's becoming more in favor, and it's becoming more standardized lah. So that might change in the future. But for now, I say if you do want to try, and go ahead. But if it gets worse, then you don't blame the doctors lah.
Okay.
Yeah.
Yeah. I see. I don't really see any questions. So yeah.
Okay.
So yeah, doctor. Before we end the session, moving on to the feedback session, any last comments before we...
Before we end, okay. So like I said before, this is a very common case lah. And if you do get this case, it's sort of expected lah for you guys to do well, because there's no shortage of patients like this. So yeah, in terms of history, we all like you guys to be very you need to have a sort of a flow lah on how to ask the history. I know you guys feel like event-based history is easy to take. That's why you shouldn't focus too much on that lah, because sometimes patients can go on tangent, right? So they say, oh, I come with this, but then I went to see that fella did this to me, and it got better for a while, and then I went to the other fella. So that one, it will be a bit of a time wastage lah. So you need to manage your time quite well. And when you take an event-based history, it doesn't really help much in terms of formulating a diagnosis. So symptom-based history is, I guess, a bit more helpful in terms of time management, and basically you can get points to achieve a diagnosis lah. So that's what I noticed during the history lah. So focus more on what symptoms you actually want to ask for, rather than what happened. Unless the what happened is significant lah, patient had trauma and all that 10 years ago, then yes, it will change your diagnosis. But yeah, you should focus a bit more on patient symptoms lah. And then examination, yeah, there's a flow which we always teach you, and you should follow that flow, because we don't want you to miss things lah, especially at your level. If it's you guys tend to stop and think, oh, what I want to do next. So that also can be a bit more time wasting, and then that gives the examiner a chance to actually challenge you. And yeah, sometimes you don't have the flow in mind, you think about what you want to do, and then that disrupts your flow, and actually disrupts your train of thought lah. So practice is very important lah for examination. I always tell you should practice on each other first, know what is normal, and you know the flow. Then when you get something which is not normal, then you can, oh, okay, I know this is something wrong about this lah. Instead of trying to practice on patients which you don't get a lot of chance. There's a lot of you. I mean, last Friday I saw at least, I don't know, 8, 9 students, and yeah, they don't get a lot of chance to examine, and the flow is not there lah. So you need to get the flow right before you this one. So so that's the two most important things lah for me, history and examination, so you can get to a diagnosis. Management, like I said, is not so heavily weighted upon lah. You need to know what is the general advice lah for management, and almost always it'll be conservative first, And then the surgery will be at the last lah. As long as you say patient fails conservative, I would recommend for total knee replacement. I guess that's enough. You don't really need to think about what sort of knee replacement and all that lah. Not at your level. Okay.
Oh, that's
Yeah.
actually,
So practice lah. Most important is practice.
okay, doctor. There's actually one more question from Eugene. Doctor, how to differentiate RA versus gouty arthritis just based on history alone?
Based on history, okay, so for RA, it's an inflammatory arthritis, and for gouty, it's a crystalline arthritis lah. First questions you need to ask is what joint is involved. So for rheumatoid arthritis, it's polyarticular, symmetrical, and most commonly involves the small joints lah. So symmetrical, so usually it will affect your PIP and MCP. And for gout, it's usually the podagra lah. So the first MTP of the big toe will be affected. And then there might be some overlap lah. They do come both with inflammatory pain. And sometimes the inflammatory pain can be quite painful lah. So that is a bit of overlap. Gout, probably if they have had gout quite a big number of times, they will know the triggers lah. So you can specifically ask what is the triggers which causes the gout. I know there's my family friend, he has gout, and he say, okay, I specifically eat this fish and then I will get gout. So that's a bit different from rheumatoid arthritis. And then for rheumatoid arthritis also, you should ask whether there's any swellings anywhere else lah. Rheumatoid arthritis is a systemic sort of disease. So you get the other the syndromes which is associated with rheumatoid arthritis lah, Feltis lah, what's the other one? Pon Jackson. Pon Jackson is something to do with the hand. But yeah, but if you're not clear, then you can just say a patient probably has some sort of inflammatory arthritis. To diagnose or get a better picture, then the investigations will help me lah. So for rheumatoid arthritis, is the serum rheumatoid factor or anti-CCP. And for gout, I guess the most important is for you to aspirate the joint and send for microscopy, not so much the uric acid lah. Okay.
Yep. Yeah, I think that's mostly it for the questions. So if there's any questions that the audience would think of, can just email and we'll compile and send to doctor. Yeah. So that is most of it for the session today. So yeah.
Okay.
Yeah, we shall end our Q&A here. So before we end the session, a huge thank you to Dr. Khairul for willing to spend a Saturday afternoon with us discussing a case, and then a lot of things to learn along the way. And yeah, huge thank you, Khairul. And before we end this session, please do leave your feedback in the feedback form, and then we will also drop the link in the we drop the link in the chat box, so please feel free to fill in the feedback form, and any feedbacks will further improve our sessions in the future. So again, a soft copy of the amended slides will then later be emailed to all those participants who have filled in the form. And once again, thank you so much for Dr. Khairul and those who all attended today. Right, thank you, Doctor.
Okay, thanks.
Right, thank you.